Alarm Fatigue by Brandy Vogelei. What is alarm fatigue? Alarm fatigue occurs when the clinician becomes overwhelmed by the sheer number of alarms, many of which are false or require no action. This situation can result in the desensitization of alarm signals. From IV pumps to kangaroo pumps, ventilator alarms to EKG alarms, there are a lot of beeps and dings that can be heard throughout the hospital. And if you're in ICU, there may be even more. An article by Margaret Funk et al. Said the studies have shown that 72% to 99% of alarms that are heard are false. That's an overwhelming amount of beeping that is quite literally nothing. This leads nurses to not respond to alarms in a timely manner, or in some cases, at all. The growing amount of alarms means so much beeping. There's an alarm for almost anything. Working ICU, you get to know the different beeps and dings. And being critical thinkers, you begin to piece together why the alarm is alarming. Why is the heart rate monitor going off? Is the heart rate too slow? Is it too fast? Is it a deadly rhythm? Or is my patient just moving or brushing their teeth? Ventilator alarms. Is there actually something wrong with the patient in the ventilator, or did my patient just cough? IV pumps. Is the infusion complete, or is there air in line? And if it's saying air in the line, is there actually air in the line? Kangaroo pumps. Is the feeding complete, or did I pause it when I turned to my patient and then I'm back and then never turned it back on? Bed alarms. Well, is my patient getting out of bed? Are they moving? Or is a family member leaning on the bed rail? Vital signs. Is that an accurate reading? Should I recycle the blood pressure? All of these are different alarms that can be heard, and these are different ways that nurses interpret them. How does that affect the patient's care? In an article by Horkan, I found an example of how alarm fatigue can affect patients' care. A 36-year-old female received hemodialysis through a right forearm AV fistula. The nurses working in the hemodialysis unit are busy administering medications and preparing for the next shift of patients. Machine alarms have been sounding intermittently on various patients throughout the shift. The female's patient's venous pressure alarm is triggered, and the nurse promptly resets the alarm and returns to her previous task. The venous pressure alarm continues to trigger, with the nurse resetting the alarm 3 separate times. The 4th time the alarm sounds and the nurse responds, the patient complains of pain in her right arm. The nurse assesses the accessed arm and discovers severe edema on the right forearm from an infiltration of the venous needle. Due to the severity of the infiltration, treatment is stopped. The patient's blood cannot be returned, which leads to a drop in the patient's hemoglobin, and the patient requires a placement of a temporary central venous catheter for dialysis while the swelling associated with the infiltration resolves. So my question is, did the alarm fatigue contribute to the compromise in the safety of this patient? I think alarm fatigue does play a role. Nurses hear multiple alarms throughout the day for things such as air in the line or a low SpO2. It's easy to go in and just hit restart on an IV pump when the nurse is passing by a room on the way to see another patient, or to ignore a monitor dinging about a low SpO2 because the last 3 times the nurse has checked on the patient, they were using their phone, or they were fidgeting, or they were eating something, all of which could cause false alarms. The nurse in the scenario was trying to provide care for the patient, and it's possible that after so many false alarms, it was easier for her just to hit restart and go back to other job responsibilities. Not good nursing, but it's easy to see how she fell into this trap. The scenario shows how harmful alarm fatigue can be, but in some cases, alarm fatigue can be deadly. So what do nurses think? A Nurse's Perspective on Clinical Alarms by Honan et al. Breaks down how nurses feel about alarms based on a collection of surveys that were given to critical care nurses. Some of the common themes that were seen in these were that alarms were tuned out based on a means of self-preservation, meaning that nurses tuned them out because oftentimes alarms were crying wolf. Another common theme was that it's not just nurses that are affected by the alarms. Alarms can affect patient or patient families. They can cause anxiety, they can cause agitation, and they can cause people being scared. Alarms that are associated with, or alarms can also be associated with conditions such as increased anxiety, ICU delirium, and ICU psychosis. Another theme that was seen was that nurses sometimes, after so much alarm fatigue, get into a rut of it's not my patient, it's not my problem. And so this affects patient care because if a nurse is in another patient room taking care of that patient, nobody is looking in on that other patient because they're waiting for the primary nurse to deal with the alarm. Nurses also spoke to the fact that they would like to be able to set their own parameters in the monitors based upon the physician's call out for range. So if the doctor says that they're okay with the blood pressure up to 180, the nurse wants to be able to set that parameter in the monitor. So that means when a blood pressure comes through at 170 something systolic, it won't ding, which means it would cut back on the nonsense alarms. Nurses also talked about how even though they appreciate having monitor staff, and I can see how they can be helpful, they also see monitor staff as a nuisance as well. But that's because sometimes monitor techs don't relay the information and they reset, and that can lead to some fall through. Another common theme was that nurses do believe that it will get better, that technology will decrease the nuisance alarms because it'll begin to get to a point where it recognizes trends. So how do we fix this problem? We know what alarm fatigue is, and we know how it can affect nurses and the patient care that they provide. Now, what do we do to fix the problem? In a couple articles that I read, one by Jepson et al. On alarm management and another that was published in the AACN Bold, they gave some pointers on how to deal with alarm fatigue. One of them was using equipment according to manufacturer recommendations, such as applying electrodes for EKGs after prepping and cleaning the skin. Also, they suggested changing out the electrodes frequently, either based on what the manufacturer says or based upon a routine. They said to apply SpO2 monitors to warm extremities, that way it gets a good read. Customizing parameters, which is one of the themes that nurses want to be able to do. And from what I understand, not every place allows this, but giving nurses the right to be able to set their clinical parameters based on what the physician has put in as a call order. Having parameters for specific units. So this would be if on a cardiology unit, based upon their typical population, they would be able to have their monitors set for a baseline for that cardiology unit. And then on a neuro unit, you would have some differences in parameters, but it would be based on that population, and then kind of individualized from there. Another thing that was suggested was providing education to staff on alarms, as well as setting standards for response. So to end alarm fatigue, we have to do it as a united front, not just for the sanity of nurses, but for the sanity of our patients and safety of our patients as well. Here are the references that I used for my project, and I hope now you have a little bit more information on alarm fatigue. Thank you.